Thank you all. It's really exciting to be here at Madison for the first time, and I'm really excited to actually present to, I think, what is actually a large Malawi contingent here. Like, there's several folks here who work in this context, so I'm hoping that this could be relevant to explaining some of what I've been working on over the past 6 years in Malawi. Great. So I think, as Monica was mentioning, like, a lot of my work is centered around like family planning and reproductive health, and essentially the promise of, like, what's motivating this particular study is the promise of family planning as an intervention or a program to improve maternal and child health outcomes, reproductive health outcomes, contraceptive and reproductive autonomy, which I know a lot of people here in Wisconsin actually work on. And when we think about the history of family planning, I mean, it has received significant attention, particularly in academic and policy discourses. And the real pivotal moment and the pivotal conference that was highlighting family planning as an issue of women's sexual and reproductive health and rights was the 1994 Cairo conference and in Cairo. And then it followed on to the 2020 FP 2020, the SDGs, the 2012 London Summit. There have been lots and lots of discourses, both in academic discourses and also as policy discourses, on the importance of family planning. And I mean, recently, there's been a lot of attention with the repeal of Roe and Wade and reproductive rights movements here in the US on thinking about the role of family planning as a means of reproductive health, agency, and autonomy, both for women, couples, families, and individuals. And so when we think about family planning broadly, like the concept to plan a family, there have been many, many different arguments that have been made as to highlight its promise, including arguments of reproductive rights, women's empowerment, and women's autonomy. So the importance of family planning as in and of itself, as an important metric and a means to its own end, but also arguments around the demographic dividend and the cascading effects of being able to more effectively space and time future pregnancy, and the links between family planning and fertility to human capital and economic development is the arguments that often have been made at the macro levels of the demographic dividend level. And I'm guessing folks have probably heard about those paradigms, but those have been done more on the macro side. And one thing that we're kind of looking at is to try and see micro level evidence of what the promise and what the cascading effects of family planning could be. And so this is what we're trying to focus on in this particular study. So the big question, if I had to say and frame the question of interest today, is to what extent does family planning contribute to some of these metrics, not only immediate metrics around adoption and contraceptive use, which are often used and have been highly criticized as they're not sufficient means to their own ends, but also fertility, health, and longer-term well-being for women, for children, and their families. And in 1994, Len Pritchett actually wrote a pretty pivotal and very important piece in Population Development Review, basically arguing for where family, desired fertility and preferences have been the main drivers of outcomes related to family planning, contraceptive use, and fertility. And the program impacts play a relatively more limited role. Many economists, demographers, other social scientists have written responses and have tempered that argument. And one of the challenges, though, is that while those debates still continue to this day, I mean, over 20 years later, almost 20 years later, one of the challenges to identify program and intervention impact is the challenge of endogenous program placement, which we often find with most interventions and policies, where to be able to identify causal impacts has been challenging, just given where programs are situated, particularly over time. So if I had to draw, causal diagrams, so this is how I would have thought about possible impacts of family planning on outcomes of interest, not just short-term outcomes, but also cascading outcomes through the causal chain. One is that there are no relationships. Maybe family planning does not have any impact on key outcomes of interest, fertility. Maybe it has no impacts on health or human capital. Maybe it has no impact on economic development. It could be that there is a causal impact, but we have to now, the challenge is now to be able to identify that impact. It could be that there's reverse causality, where family planning programs have positive impacts, but there are feedback effects where socioeconomic status and socioeconomic development also contribute to contraceptive use and the adoption and the placement of programs. And of course, there could be other factors, right, that end up driving both common causes of both family planning and outcomes of interest. So the identification to be able to actually ascertain whether the true impact of family planning is a challenge in this field. When we look at the evidence empirically, we actually find pretty mixed observational evidence, where we find mixed evidence of impact, but also within evidence of impact, very mixed evidence of effect size. When we look and turn to trials, and when we look and see what are quasi-experimental or experimental evidence of programs and interventions, and particularly in LMICs, we find that there's quite a bit of evidence from quasi-experimental studies, and these are studies that are often cited the most in this field, like the MATLAB study in Bangladesh and the Navrongo study in Ghana are often the two first stage studies that are cited in family planning and reproductive health, because they've been following cohorts for a very long time. But one of the challenges with both of these studies is that, like the MATLAB study, as important as it has been for giving insight and inference, it was a very big multi-component intervention where treatment and control sites and villages were not quite clear how they were selected. And family planning was just one small component of a much larger package of services. So to be able to disentangle that impact from other maternal and child health services that were given has been a challenge, right? And that's something that empirical social scientists have found challenging. And most evidence of the impact of family planning, not just for the sake of use or adoption, but going beyond contraceptive use as the endpoint, are from evaluations where the intervention of interest has been part of a much larger suite of services. So this was kind of the motivation for our team to be able to think about impact evaluations and trials of family planning, where the intervention and the focus is really on family planning, both on impacts for short-term outcomes, but also thinking about longer-term and even intermediate-term outcomes that could suggest broader welfare effects beyond just utilization and change in contraceptive behavior. So what I present to you today is a series of results from a randomized control trial of a family planning intervention in Lilongwe, which is the capital of Malawi. And the aim was to really try to assess the role of improved access to family planning. And the intervention is a multi-component intervention, but focused exclusively on the improved access and provision of family planning services. Just a bit of context for those who work in Malawi, this is not unusual, but for those who haven't, the national total fertility rate of Malawi is around 4.2 children per woman, which is actually quite modest and even on the lower side of fertility in sub-Saharan Africa. Sub-Saharan Africa has experienced modest fertility decline, especially over the last 15 to 20 years. And in Lilongwe, being the capital, we often see lower fertility in urban settings compared to rural settings. What is actually really, really important is that when we measured contraceptive prevalence, so the study started in around 2016, field preparation started in 2016 and continued all the way to baseline and end lines continued all the way to 2020. So right when we were starting is when the Demographic and Health Survey was done in Malawi, and we didn't have that data out. And what we did when we realized, which kind of was a little concerning for us, particularly when it came to power, is that contraceptive prevalence in Malawi has increased significantly over time. Yes. No such thing. Mm-hmm. No. So I think one of the things that we were trying to really work on in this study is that when we say family planning, it's a suite of services that include not just the delivery of the provision of contraceptive services, but also including counseling and other components that actually go into how women and couples may better space and time pregnancy. So this includes, for example, and I'll show you the suite of interventions that we were able to provide, which included counseling, included transport to clinics and back, and it also included the provision, financial reimbursement for any suite of services that were related to family planning and reproductive health at the clinic where we worked. So this included cost of pregnancy tests, the cost of methods themselves. insertion, removal of methods, but also follow-up, like including the treatment of contraceptive-related side effects, for example. Yeah. Mm-hmm. Oh, right. Right. So yeah, exactly. So what the package is kind of focusing on is elements that are not directly related to what happens post-pregnancy. Like, so once women become pregnant, the other suite of services like antenatal care, like for example, facility delivery, etc., those are not part of services that we directly identify and provide as this particular suite of services. It's a much more targeted set of services that a family planning program often seeks to achieve and provide, that is often separate from other maternal health services that are provided as part of a larger program. Family planning is often embedded and integrated with MCH, but there are, when it comes down to actual intervention components, there are distinctions between what is provided as part of a family planning program and what is provided as a broader suite of services. Yeah. So in thinking about our context, like we have seen a large, I mean, if contraceptive use and adoption of services was the first outcome, then we already are a little bit concerned about our setting, and I'll explain why this concern was an important feature of our entire study, is that contraceptive use and prevalence is already increasing substantially. Malawi has received a lot of external donor support. It's been considered a key priority country for family planning and reproductive health more generally by the UN and by other international institutions. So a lot of investment has gone into improving service provision, particularly, but with the aims of specifically increasing contraceptive use. So this is the context that we're already working in. And what we actually see is that in spite of this increase in contraceptive prevalence, if that was the first indicator, we still see that about 30% of births are, in the past 5 years, at the time when the Demographic and Health Survey was done, are missed times. So women would have said that they would have preferred that birth later or at a different time, and 11% were not wanted. So there's still these mismatches between, even in spite of increased access more generally and more nationally, in terms of actual meeting women's fertility preferences and goals. Extra motivation. So one of the recommendations that is often cited is the WHO recommendation that women wait at least 24 months between their last birth and their subsequent pregnancy. So they wait for 24 months before they get pregnant again before attempting the next pregnancy, in order to minimize risks that are associated with short birth intervals, including maternal depletion syndrome and other maternal and child impacts on short birth intervals, including particularly when it comes to maternal recovery, specifically for those women who may have had risky births or may have had more high risk pregnancies. And so that combined with actually a lot of work that Monica herself and others in this room have done, is that there's a desire for women and couples to better space and time pregnancy. So when I did these qualitative interviews and formative work, women would often say, I want my next child when my current one can walk. I know with Monica's work is I want my next child when my current one can go to school, start at school. So the desire for spacing and lengthening pregnancy is something that we're actually observing in this context, both from women as well as from men, to be able to think about timing and spacing their subsequent birth. And the role of family planning in this is actually quite important, because when we think about planning a family, it's not just about limiting pregnancy, which is often the first thing that we think about when we're talking about contraception, but also how the suite of services, contraception, counseling, etc., can also allow women and couples to better time and space pregnancy so that they can have the number of children that they want when they want them. So what we do is we conduct a trial that assesses the causal impact of a multi-component family planning specific intervention on, we look at utilization, so that includes contraceptive use and method mix as the outcomes that we were primarily powered for to start, because those are outcomes that have been traditionally observed in this field. But we also start looking, and we look at pregnancy and particularly the risk to short birth intervals as our outcome of interest. And we start looking at child health and physical growth, because the surveys, as you probably see, imagine the demographic and health survey. We also combine anthropometrics, so we measure every woman and child under 6 over our time periods. We also collect data on labor market like outcomes, time use data. It's a very rich data set that we actually have access to and that we're able to follow women for and children for over our 3-year period annually. And so what I'm actually like highlighting in blue here in terms of like economic outcomes is that we are just finished some of our preliminary analysis on women's work and on time use. So I'm able to provide some preliminary results to that, that analysis. So experimental setup. Oh, yes. Hi, Priya. Yes. Absolutely. So in our sample, so the sample that I'm looking at specifically are women who are pregnant or immediate postpartum at the time of recruitment. So these are women who are either currently about to have children or they've very recently, up to 6 months ago, had children. Because the reason why we picked these women, and that was our selection criteria, is to see what would happen, like if they're able to meet their birth spacing requirement and their birth spacing recommendation that the WHO had identified. So if we think about women who have, either are pregnant or have a small child, one of the immediate constraints is transport and like physical access. And so women, as like a lot of family planning in terms of service provision is provided for free, especially in the public sector in Malawi. However, the travel distances and with women preferring not to go to their clinic that is closest to their homes, but actually slightly farther out in order to avoid any stigma, in order to avoid any other issues and barriers that they may face from communities. They would prefer to go outside the communities, but with a small child, it becomes harder to travel. And so women, as free as it may be, and as high quality as some of the care may be, in particular in private settings, women were like, we're not going to travel and take 2 matatus and like a bus in order to travel an hour and a half just to get a preventative service like family planning, even though they would have preferred not to have another child soon. So barriers in terms of physical access, as well as knowledge is still and priming of particular methods is also a concern, but there's definitely a different concern when you're thinking about pregnant or immediate postpartum women and how their needs may be slightly different and their demands and preferences may be different compared to with standard, like other women who are not in that category. So what we did was that we went to areas in Lilongwe. We screened about 11,500 households, and we had our eventual sample of 2,100 women. And I'll just quickly, the criteria is that these women were slightly younger, so they were 18 to 35, married, living in Lilongwe, and they were either pregnant or postpartum, immediate postpartum at the time of recruitment. And so then we randomized women into 2 groups, and then we did annual follow-ups. We had a first-year follow-up, a second-year follow-up in 2019, and we just finished our 3rd follow-up, but I mean, because of COVID, we could not do another annual one. So we had about 2.5 to 3 years in between the latest follow-up, which we just finished last October. So we're still in the process of cleaning and analyzing that data. So we had respondents who were 18 to 35, married. And as I mentioned, we also interviewed and actually measured all children under 6 of women who were in the household. So any child under 6, we measured them both in terms of anthropometrics, so child height, child weight. We also took anemia measurements for both women and for children, and also measured women's height and weight. And what we're actually presenting is some of the child health results for the index children. So the children who made the women eligible for the study. So the woman was either pregnant with this child, or she would have given birth in a subsequent wave to that child that made her eligible for that study. So we have some results of both child health, physical health, and cognitive development for those children. But the main important point to note on this is that the eligible woman was the primary respondent, and that she was the one who determined eligibility into the study. So baseline survey, we started in September 2016, completed by 2017. As I mentioned, it's a really rich survey. I'm completely overwhelmed with data. Anybody who's looking for data, I am more than happy to talk to you about how we can actually make this data more accessible and utilized, because there are many different components. We have household questionnaires, we have like data on expenditures at the house, consumption, we have the woman's questionnaire on fertility. We also have the reproductive calendar, so we actually have retrospective histories on reproduction and pregnancy. We have employment histories and time use, like labor force participation, and then we also do physical health and like a biomarker data collection with anemia and anthro. Yes. Yeah, great question. We tried our best to follow up with children, but especially with children, once they started getting to school age, they would start exiting the house and they were less likely to be available at home. So, and because we were only going back to find women who are primary respondents, it was much harder to start tracking children, and just given our limited resources to actually see when they could come back to school, come back home from school. Yeah. Right, and there was a second reason, because we did anthro for all children under 6, but our key respondents were these children who were younger. The second reason was that in our anthropometric module, one of the things that we did was anemia testing. And in Malawi, there's a very sensitive cultural norm with blood and blood data collection. And so as it is, it's a very sensitized topic about like data collection, where there's a cultural reference about the use of blood, particularly for like rituals, etc. And when we started collecting data, what happened in the middle of one of our data collection waves was a scare and a rumor that was passed out where the disposal of biohazard data collection for blood was improperly handled by another study. And what ended up happening was that there was a rumor going around, not just in Lilongwe, but across the country, of like vampirism, satanic rituals, of researchers using data collection in blood for nefarious purposes, etc. So not only did our study have to stop, where the Ministry of Health like shut down all data collection related to blood data collection, including the big HIV surveys that are often done in Malawi. And so we just had like huge levels of attrition that we just could not, we went to those households, the kids were there, we just couldn't collect any data from those kids. We lost about half our sample due to that. And we can show you like how, like, to the best of our ability, we like, do bounds analyses and we do like selection models to show that there are no differential impacts, but just given the size of the attrition, it's very hard for us to say, other than like the shock that like happened during data collection, we could just couldn't overcome it. Something that I learned, like we learned the hard way when we were there. And like, I mean, it was, I really felt a lot, especially for the HIV testing and the HIV surveys, and because they're large national longitudinal surveys that were all essentially had to stop for about 6 months before things could get better again. And even then, there was a lot of skepticism around like consent, particularly because we consent the entire module for those children. Yeah. So the intervention, one of the things that we did beforehand, before we actually implemented any part of our intervention, was that we went to an informative work, qualitative work to understand the family planning service environment, especially given this rapid change and this increased influx in investment in this field. We worked with the Ministry of Health and the Reproductive Health Directorate of Malawi directly to make sure that the components that we were proposing were not just policy relevant, but also potentially scalable. And so we also measured costs and take up at all different points of the intervention. And the key insight was that we were trying to really think about the birth spacing and timing recommendation to see if we could rigorously provide an intervention that could rigorously test and disentangle that component, if that component could be met by the recommended practice that the WHO had instilled in family planning as a birth spacing and timing mechanism. So this was a 2-year intervention, and it consisted of 3 components. Component 1 was that we went and we gave free transport, so a taxi service that would take women from their homes to our clinic that was this is Population Services International. It's a very big social franchising NGO. And they have private clinics all around Malawi and in many other countries where they provide contraceptive services, high quality, very low stockouts, low waiting times, but they are a private clinic, so they provide a fee for service, right? So we partnered with one of the PSI clinics that was like reputable and also that had been identified by PSI to provide like high quality services. So we were essentially controlling for the supply side, very low stockouts and low, like good waiting times, etc. If a woman wanted to use the service, she could call McDonald was our driver. And by the way, we actually knew the entire network of taxis. So if anybody goes to Lilongwe and needs a taxi, like you can find me and I'll tell you them all because we mapped out the full network of taxis that were available. And we had them, we gave women the number of our taxi driver and they could call the taxi driver, set up an appointment. They would get picked up by our taxi driver as well as a female field manager who was always in the car because there was a stigma against getting into a car with an unknown man. In the taxi, particularly in the community. So we always had a woman field manager in the taxi with the woman and the driver, and they would get transported to our Kalma clinic. It was usually the median length of transport was about 20 minutes relative to an hour and 15 minutes that women would normally have to go otherwise because it was farther out. We also provided 6 counseling sessions. Counselors were hired by the Kamuzu College of Nursing. So they were recent nursing graduates who had yet to find employment. And so we didn't want to displace existing human resources because as it is, Malawi is very constrained, particularly for nurses. So we were hiring counselors that had yet to find full-time employment, but they were trained in nursing and we trained them with the Ministry of Health. We actually had one of their master trainers come and train these women counselors on a series of sessions that covered family planning and reproductive health topics, including return to fertility, which was very important for women. A lot of women did not know that they could get pregnant again as soon as 3 weeks following a delivery, especially if they were not exclusively breastfeeding or using breastfeeding as a method of contraception. They did not they were the links between breastfeeding and a lot of women in Malawi breastfeed. So thinking about using lactational amenorrhea as a method of contraception, they were trained on how that could actually facilitate some of their use. Thinking about the impacts of family planning on potential child health outcomes, thinking about the birth spacing and timing arguments. Those are all baked in as part of this ministry-oriented training that was facilitated by the Reproductive Health Directorate, and we were supporting it. So these counselors were trained over 6 sessions to provide counseling to women over a 2-year period. And the final thing that we provided, which was actually very important, was reimbursement for services. So this was not a voucher. So women were not actually getting any cash transferred. There was any service that they were getting that was family planning related. We were there at the clinic, waiting for them, and they would be treated as they were a normal patient, but then a normal client. And then at the end of the service, our field manager would just cover the cost. And we would only cover costs related to family planning, so contraceptive methods, any tests that were necessary, particularly pregnancy and HIV tests that were related to family planning. And the big one was reimbursement for contraceptive-related side effects. So family planning is a free service in Malawi. However, one of the things that we learned was that if a woman experiences a contraindication or a contraceptive-related side effect, that may be classified as a medical issue, and that medical concern or that medical effect would no longer be covered under this umbrella that is free. So women would have to be paying out of pocket for services if it was classified as a non-family planning related medical expense. So a lot of women actually reported that because of the high prevalence of perceived side effects in our area, a lot of women were saying we don't want to use family planning specifically because we are afraid of getting a side effect, and then we'd have to incur payments out of pocket. So to avoid or alleviate that issue, we covered all components of care that were related to family planning, including side effects management, the methods, any other services that were related in the clinic. So for any methods that were clinical, insertion, removal of methods was also covered. Yes. Hi. No, we were pretty strict about this. So the way that we tracked all of, actually, let me see if I have, oh, this is the brochure. Let me see if I have, oh, there we go, ID cards. Okay. One of the things that we did was that we had personalized ID cards made for all of our women in the treatment group. And they were very explicitly told that this takes you from your home to the Kalma clinic and back. Like there was no other, like we were really limiting and excluding any other possible like impacts. Like because if the Kalma clinic was near the market and they could go to the market, like that was not something that we could cover. So they were not using it just to go to seek other amenities or other services that they may have wanted. Yes, exactly. So the reason why we didn't tell the clinicians or the medical staff at the clinic that this was a woman from our study is that if the woman was maybe like getting a treatment for malaria, for example, but like the clinician may like code that as saying that they could get, it was as family planning, and so they would get covered. So we did not actually interact with the clinician until the very end when they actually had to pay fee for service. So we were trying to minimize any of these other possible contaminations that were outside of the family planning domain that we were covering. Yeah. So this is the Tunza clinic. Yes. At home. So it was at home, and actually the promise that I had made where I would maybe cover a second study has to do with male partners. So I'll try my best to get to that. But what this was individual counseling at the home, and women always had the opportunity to invite their male partners if they wanted. So if a male partner was invited and we documented that, if they were at home and they were available, we would counsel the couple together. But this was at the discretion of the woman, because the target recipient for counseling and when we would see women was at home, and it started privately for this intervention. In an intervention that maybe I can speak about later if I have time, is that we actually gave like the nudge, the behavioral nudge was to actually encourage women to invite their partners if they wanted to, but women still had the choice whether or not to invite. So you end up having the selection where some women, like if they believe that they may be more aligned in their preferences for contraception as well as with fertility, they may just choose to invite their husbands or their partners, and some women may actively choose not to. So we have data to be able to disentangle that. In this study, we don't have as much like uptake from men, because men often are not even available in the homes. When we go and we interview them, they often are outside, out of the home. But if they are at home and women are like okay with them to participate, that's fine. But the counselor left that choice up to women for this study. Yeah. So yeah, so this is the clinic. I mean, and as this is on a typical day. So this is actually as non-crowded as it is relative to public clinics. Like this is actually a very de-densified, like not crowded clinic where you still have about maybe 8 to 10 women like outside the clinic. Like in public clinics, like especially during family planning days, it's just inundated. I mean, there's hundreds of women outside with their children. This is actually, I happened to be there when women were actually getting weighed and measured as part of like a clinic outreach day. So there are like a lot of clinics actually have programs for outreach for other services. And I'm sorry, this isn't Chichewa, but this is actually the brochure of the 6 different sessions that we would give to talk about the different themes in each of the counseling sessions. So here on this left side is about breastfeeding and about the role of return to fertility and breastfeeding. In the middle, it's about like the importance of like the possible links between family planning and child health. We have some information about contraceptive methods. And then actually on the back side, we actually have a lot of myths and misperceptions around family planning, particularly around prevalence of side effects, et cetera, and common concerns that women would have. And we would have like, here's what women may say, here's what like the data seems to say, and what some of those correcting some of those beliefs, possibly based on what women say. Yeah. So this is actually the ID card. So every woman got a personalized ID card, and then we also gave them like a transport voucher in the event that the taxi that they called, like our primary taxi that they called, was unavailable, because we knew the network of taxis, this voucher was good if they ever had an emergency service or some other service during non-operations hours. They could just hand this voucher to any of the taxis in Lilongwe, and then they would like have the information of our field managers. They would call us back, and then we'd reimburse all the services. Women could also go to other clinics outside of our Kauma PSI clinic. If they wanted to go to a local clinic, they totally could. They could go anywhere they wanted, but if they went outside and we were not posted in those clinics, they would just have to keep receipts, and then we'd reimburse them after. Or they would just give the number of the clinician or the medical provider at the clinic to call us, and then we would reconcile expenses on their behalf if they were credit constrained. So any sort of financial alleviation is essentially what we were looking for. Yeah. So we have data on, like, as important as it is to have, like, the baseline and follow-up data, like the data collection, we also have data on every time a woman interacted with any component of our intervention, which is part of our program evaluation and process evaluation data, where every time a woman had a counseling visit, we recorded the counseling visit, we recorded what data was, what was being discussed, who was part of the visit. All of this was part of that data set. Every time a woman took a taxi or even called a taxi, we have the transport logs and utilization, how far the taxi went, etc. We have clinic visit data. So we also know from the admin data whether, like, a woman came, did she get any sort of service? Was it only a consultation? Was it an actual service? And we also have data on the cost for that. And then we also have reimbursement logs. So we keep lots and lots of data and we triangulate them. And we're still in the process of this is me being overwhelmed with data. I'm still triangulating a lot of this data to actually kind of get at the question that a lot of social scientists and a lot of the economists often ask, which is like, what's the mechanism? Which of these components is maybe driving the action? And I have some insight that I can give, but I don't have the tables for you. But what seems to be happening, and we'll show you, is that the counseling seems to really shape the preferences, and often tends to, women who are getting more counseling often change their minds around what type of methods are like more suited for them. But the thing that actually drives women to change their behavior is the transport. And so just a preview of like my earlier discussion with John was one of the things that comes out of this, and this is something we've been having discussions with the Ministry of Health and the Reproductive Health Director on, is that transport, which is not a health service directly and is often not it's related to, but not often incorporated as part of health systems infrastructure or health systems service provision, was key to actually getting these women who were transport and mobility constrained to the services that they wanted. And that often is outside of the purview of the Ministry of Health. So if that's where a lot of the margin lies, right? Particularly for women to be able to translate their preferences for contraception and for family planning into outcomes, then there's a big hard think from the ministerial side to see how this goes. Yeah. Oh, yeah, question?
I wonder if the police have a government.
Right. So it's not Uber necessarily that we'd have to think about what the policy relevance and the scale. So the scalability of the transport component of all of the other components is probably the least scalable as it currently is. One of the things that actually has been happening in other countries and contexts is like more concerted transport options, particularly for pregnant women and for postpartum women, particularly around the time of delivery. So there are other interventions that have been scaled at a much higher level than this very localized study on thinking about like particularly getting women to antenatal care, particularly getting women to delivery, but they're using the public infrastructure to be able to do so, where they're either subsidizing or fully covering women who are actually seeking ANC visits or facility delivery. I think the facility delivery one is actually the particularly more salient intervention that has been implemented more broadly. So we can learn from some of these other studies about how, to what extent can this margin, which seems to be like particularly salient for some of these results, to what extent can it be scalable? And what are some of the barriers that we may actually, constraints that we may face for preventing scale? Yeah, from inhibiting scale. So we're still working on this particular thing, but like one of the conversations that always comes up is, are you sure it's really the transport? Because, and you can see why Minister of Health or like a Minister of Health might be concerned on that, because that often is outside of their sector. And if sectors are often vertically financed, then it becomes hard to have cross-sectoral support for an outcome that's not directly related to what they work on. So something like more food for thought, I guess, than an actual solution at this time. So I'm just going to present some really quick results. I don't want to overwhelm us with too many tables, but what we actually find in our results is that at the second year, because our outcomes were powered for our first stage outcomes were powered for the second year, where we find the treatment effect, women who were part of this treatment had about a 6 percentage point, 5.7 to 5.8 percentage point higher likelihood of taking up contraception. So contraceptive prevalence was 5.8 percentage points higher. This is on a baseline of around 58 or 59% of our sample. And that translates to about a 10% increase, relatively speaking. What we actually see, which is particularly interesting, is that women are no more likely to take up injectables, and injectables are the most prevalent and predominant method in Malawi and actually in East Africa more generally. And injectables are given every 3 months. What women are actually changing to is predominantly implants. And so they're switching away, it seems to be, or adopting implants over injectables, even though injectables are the more common method that are used. Yes. Mm-hmm. Yeah. Yep. That's pretty much what we see. And I don't present some of the data when I'm trying to mediate the impacts, because you have to now think of structural equation modeling and mediation of what is driving this one argument, one possible channel. And what you're actually seeing is that because implants are the Jadel is usually about 3 to 5 years, depending on the I think there are different variations, and I think it's 3 years is what they have in Malawi, and in Norplan is also 3 years in Lilongwe. And what you actually see is that women are taking it up pretty quick, and then they don't have to return again to the clinic for follow-up or services unless they had a contraindication, which is in our sample, we provided women with access to contraindication and side effects management. Over the 2 years that we actually had followed up women, about 18 women out of our sample of 1,000 came in because they had a contraindication that they reported and they were treated for that management. So the prevalence, if we just go by the sheer numbers, the prevalence of contraindications and side effects, even as they were switching to longer acting reversible contraception, is lower than what we had, the perceived likelihood or perceived probability of it in experiencing a side effect was. Yes. Mm-hmm. Mm-hmm. Right. So what we are able to do is that we have 5-year follow-up now, and we're just started analyzing the removal. So what we're actually seeing is that I can't present these results because they're super preliminary because we just collected them, but we don't see much of discontinuation. And actually at 2 years, we see some discontinuation even of implants because women are actually maybe trying to get pregnant again. So there's this, yeah. Right. So this is something which, we were pretty, we're just constrained in terms of how long the service provision can continue. So we have funding for 2 years of service delivery. And so one of the things that we're actually this is actually definitely a concern, which is removal is actually so much bigger of a barrier than the initial insertion. And so if women are not, during the time when we were providing the service, women had full access to removal, especially in the private sector. Removal is also provided in the public sector, but it is much more costly in terms of finding the provider. It's the time is longer. There's all these, even though it's free in public sector providers to remove, the cost barriers are different, and they're now compounding in other ways that we cannot prevent in this particular intervention. So we have data. The best we can do right now is monitor how removal and insertion works, but whether it's followed up with actual, how we could intervene on it at this stage, we could not. Yeah, beyond 2 years. Yeah. Yeah. Mm-hmm. Right. Absolutely. So one of the things that we are like in the process evaluation data, which I just am showing the ITT results. But in the process evaluation data, we have data on whether women, because women could choose any component or any combination of services that we had provided. So if a woman after like 2 counseling sessions was like, I'm done, I know it's nice to talk to you, but you don't need to keep coming back and having multiple counseling sessions, that was okay. We would just follow up and say, you would like another session? She could refuse and that would be fine. So we have variation in counseling. We have variation in transport. And we also have variation in actual utilization of services, not just at our clinic, but also whether women chose to go more locally or to other clinics that were not part of our one clinic network. So we have that data, and we can and women were free to choose whatever combination they wanted. Yeah. So we have that data, and what we find is that like a lot of women actually did go to like the majority of women that we had in our study ended up going to our Kalma clinic, specifically because it was just easier for them to like facilitate that entire process there. But some women actually did go outside of Kalma to like either other PSI clinics, other clinics from other networks, or to public clinics. And we record and document that variation. And there's not much difference. I mean, like the other group is pretty small, so it's hard to do a statistical comparison of differences, but there's not much difference from what we can see, at least in raw data, of women who decided to go somewhere else. But we were still covering their service. We were still reimbursing, but yeah, that was, yeah. Yeah, so exactly. So like we were trying to at least control for some of the supply side by saying, like, if we truly gave women access to any sort of clinics, then there would be variation in the supply side on like the types of clinics that women could go to. So in order to just say like, here's the reference that we're able to provide, and we're providing kind of like we're trying to provide like that upper bound on the supply side to see like if women did want access to what we told them that this was a clinic that was highly reputable, that had very good supply. So they understood that this was a clinic that could be the best supply side that they could probably get or be offered in Lilongwe. We're just kind of bounding our expectation, and like any other clinic would, of course, for other reasons be preferred. But at least we wanted to make sure that women could get access to this service no matter where they're coming from. Yeah. Mm-hmm. Yeah, that's right. Yeah. So when we are doing some of the like mediation analysis and also some of the when we started like disentangling some of these components, like there's endogenous selection. So like women can choose to take more counseling or choose to take more transport. They can choose to go to Kalma, but like, and the transport only goes to Kalma. It doesn't take them to any other clinic. So if they wanted to go to another clinic and they were getting covered, then we could cover them. But that was like the transport is primarily to our clinic. So there's selection in terms of, and there's also variation across women in what they choose to take up and what they choose not to take up. So we actually are trying to like exploit some of that variation. It is non-random. So we do have to like, I mean, we can at best say like women who are more likely to take transport are more, I mean, we're just like creating associations by explaining some of these effects and trying to break down the variation in some of these effects. It's not a causal, it's not as rigorous or robust of a causal mediation as one would hope, because the mediator itself is like, I mean, it's not randomized, or it's endogenously selected. But we have data on it, and there's variation, and there is variation. So we're trying to exploit some of that to see like, how do two women that were given the same access, like the same suite of services, how they may have chosen different combinations to be able to see how their like results and how their outcomes may be different. Yeah. Mm-hmm. Yeah. Mhm.
A lot of that.
Yeah.
In the sense that you actually have the power, and also powers a lot of
Right. Yeah. No, absolutely. So I think that, so in this context, like oftentimes like women and I mean, couple and male involvement is actually quite preferred. And a lot of women actually like when in the follow-up study, and also in this study, we actually asked women, like, do you talk to your husbands about family planning? Like, does your husband know whether you're using contraception or not using contraception? Like 90% of women like say that their husbands know and that they're involved in decision-making. But when we actually did recruitment, both for logistical reasons, but also for the fact that this was a woman-centered design to start. Like our follow-up studies include partners, but this initial study is a woman-centered design. Women have like we're approaching the woman, and if the woman wants to involve her partner or not, the extent to which he's involved is her choice. And this is often actually how even service provision in family planning is like not only perceived but operationalized, where on all else being equal, the choice of women to either access or not accessing care, like it's very much targeted and oriented to women being deciding whether or not they want to be involved. Right, and but like, so in this context, not as much. Like when family planning is a pretty ubiquitous service, and like I mean, this was like I have studies in South Asia, and it's a very different environment where family planning is much more stigmatized, and like also like the type of contraception is also it's a very different environment. Here, access to family planning is known. There may still be stigma about which type of women may choose to go and seek services, but these are all women who are married and who've already had one child. So the selection of the sample itself tends to like limit some of that like concern around stigma, because these are all women who've already proven their fertility and who are married. So the use of contraception for spacing and timing is less concerning than, for example, if I would have loved to do things with like adolescents or unmarried women, but there are all these other constraints that come in when you're trying to understand how family planning and reproductive health are received by those groups. Yeah. Hi. So these are not women who've all had one child, but they're all married. Sorry, I apologize. So some of these women also have this is their first child, but they're going to have a child because they're pregnant when they are recruited. So in some ways, like fertility has already been proven, where like, I mean, actually this goes around the world. It's very hard for family planning to be adopted by couples who yet to have a child, because there's often a lot of normative pressure on women and on couples to prove their fertility. So timing to first birth, like family planning often is not very successful at delaying timing to first birth, but subsequent births is where family planning often tends to be more successful in terms of spacing. Yeah. Mm-hmm. Not in Malawi. Like, so it's not like India where there's a very like significant gender preference and son preference. In Malawi, actually, when we ask questions around fertility preferences, we ask about like ideal composition of children. It's pretty much balanced. Like around the world, like we actually find that there's even very marginal son preference. But in this context, even in high income countries, like, I think conventional statistics and like the general stylized fact is that people, both men and women, often want to slightly marginally prefer a son first, and then they want gender balance. But here in this context, like we don't see any discernible differences in sex composition or preferences. Actually, at baseline as well as in follow-up, like they're pretty balanced all the way through. Yeah, hi. Yeah. Yeah. Yeah, so we don't find as much, like we don't find as strong of differences in, I mean, we like women who want to postpone or like who have a stated preference for postponing their next pregnancy at baseline, like we stratify by that in a robot, like in a subgroup analysis. We find that women who want to postpone or have stated like clearly that they want to space or time their future pregnancy are more likely to also adopt and also have higher uptake. But the differences is the difference even amongst women who are ambivalent, it's not as big as one would think. Like even women who are more ambivalent are also more likely to take up and like not only use contraception in at like not only midline but endline, but they also have changes in preferences. So like women who are more ambivalent, we actually find that our intervention may actually be reducing the uncertainty, like the preference uncertainty when we look at the impact of this program on preferences. It's on preferences themselves. And this is something which actually motivated our next study, which I'm unfortunately not able to talk about very much, but that was actually around thinking about this concordance, like basically going beyond just contraceptive use, but thinking about contraceptive concordance, which is how do stated preferences actually translate to behavior? And like, are we able to actually connect whether if women say, this is what women say they wanted at a particular point in time, to what extent are they changing their minds? To what extent are those minds that are being changed actually being reflective in what they actually do and what they get? And does it actually all concord at the end? And that's actually a second study on the role of male involvement in that concordance, but also tailored counseling, which is taking this counseling and updating it with like a more tailored counseling session. And that's like a second study that I'm happy to discuss. But yeah, yeah. So I think that, so these are our first intent to treat results on contraceptive use. And actually what's important to like actually the key outcome, which was what we were looking and seeing to be powered for, was birth intervals. And like this is like the Kaplan-Meier plot of the hazard of short birth intervals. And what you actually see is that in 1 year, there's not much of a difference, but that's also because several of the women who, like half of our sample at baseline were pregnant at the time when we had like recruited them. And what you actually see is that the hazard, like the control group is more likely to be like have a risk of pregnancy. And this is like the risk of non-pregnancy, like non-pregnancy. So the treated group is more likely to not be at risk or have a lower risk of short birth intervals. And actually by a pretty significant amount. The hazard of a short birth interval in the treatment group is about 44% or 43 to 44% lower than in the control group. And this is actually something that we found to be pretty meaningful, because what it's actually saying is that like within the, like to meet that WHO recommendation, we actually are seeing that women are more likely to be able to meet it with our intervention. We also, as I mentioned, have data on height, and also we have data on child height as well as on child cognitive development measures. And what we actually see in this, these are just plotting the distributions, is that in 2016, the index children, there's no difference in the distributions in terms of height for age. But we actually see that children who are part of our intervention group, who are the index children, are about 0.24, like 0.2 or 0.24 standard deviations taller for their age relative to children who are in the control group. Just a quick summary, it's a 6 percentage point increase in contraceptive use, shifting to longer acting methods, lower risk of pregnancy in 2 years, and about a 44% decline in the hazard. This is our results on child health, like outcomes. So we have both height for age, that distribution that I just showed, as well as CREDI scores. And CREDI scores are a measure of early childhood development. So we actually were able to, like, I mean, this is my favorite part of the surveys, where we actually like play with the children. We have games to be able to test cognitive development, functioning. So we actually see like if they have better movement. And I mean, these are all like, for anybody who does ECD, this is amazing and I love it. And it's actually good to see like how children like develop over time. And what we actually find is that children in our treatment group have about a 0.1 standard deviation higher CREDI score, so are more have higher levels of cognitive development, relative to children in our control group. And this is something which I'm presenting, it's like not the best, and I'm gonna be perfectly upfront about this because for exactly the points that were made earlier, is that when we try to do like a rough mediation analysis, and like you have to make quite a few assumptions about sequential ignorability and all these other issues when the causal mediation analysis, the mediator itself is not like random, but what you actually see is that a lot of our, like a significant portion of our causal impact for child scores, like especially for child growth and development, is mediated through the healthcare utilization, the increase in healthcare utilization that their mothers are getting, probably because they're coming to our clinic. So that's what we are actually able to observe. And I wouldn't take too much into this, particularly given attrition, particularly given other issues when it came to the actual measurement of children. But the data suggests that there is an increase in healthcare utilization, and that increase seems to be translating to improved child growth and functioning in follow-up. Now, one of the things that was, so here are the summaries. So some of the impacts are mediated through healthcare utilization. Of course, I think I mentioned because of the attrition problem, like I think this was brought up right up front, is that we did a lot of like testing. So we did like Heckman selection, we did, bounds analysis, propensity score weighting, and we tried to find, and we also did like just raw comparisons of groups. We didn't find anything observable in terms of differences because this seems to be like a true exogenous shock that we just could not have anticipated. So there was no differential selection across our groups. And actually the Heckman selection, we were able to do it because our counselors were randomized to women, as were our enumerators. So we were able to actually get some, like use that as like instruments for like, is there selection into consenting or not consenting? But we didn't see any of that in our data. So like, given how big the 40% attrition in children, pretty massive. Can't say this, like these are no longer causal estimates, just given the attrition rate, but there doesn't seem to be differential attrition based on what we are able to observe. Very preliminary results. We're actually finding that the intervention seems to have an impact on women's work and on labor market outcomes, where after 2 years of intervention exposure, we're finding that women were 5.2 percentage points more likely to be employed. This is actually like already, the 5.2 percentage point is actually relatively modest. It's a significant impact, but it's modest because when you look at employment for women in this context, labor force participation is already very high for women because they're often working in the informal sector. And this is just a general stylized fact also in sub-Saharan Africa, where women are often underemployed and are working in informal sectors, but they are working. There is work there, and how we measure women's work is a whole other discussion that I'm happy to get with anybody here. But like how we even ask some of these questions in labor market surveys is not necessarily conducive for measuring or estimating the true economic contributions of women in this context. We also find that they're higher and more likely to participate in wage earning labor, but there were no significant differences in earnings. And what we actually find is that there's no differences in male labor supply, and which seems to suggest that if you take those two observations together, that overall household labor supply seems to have increased over this period when women were getting access to this program. We tried another very quick mediation analysis. I know we have, for any economists who are out here, we do structural modeling, and then we have to go into mechanisms and think about parameter estimation. But our quick, just a glimpse of a mediation analysis seems to show that our short-term fertility changes, where women are spacing or are less likely to have a short birth interval, are partially explaining some of these changes to employment and labor force participation. So just taken together of these results, for anybody who's been working on the demographic dividend and thinking about the role of declining fertility on labor market outcomes and on human capital and health, the main motivation, as I mentioned, of this project was trying to understand the demographic dividend at the household level, because especially in sub-Saharan Africa, a lot more of the variation and a lot more of the impacts of changing family structure and family size and fertility are actually happening more locally than some of the aggregate national level macro trends seem to suggest. So this is kind of from soup to nuts, trying to get from one end of the spectrum to the other and trying to get some evidence of what we can get as more rigorous like evidence of these types of causal pathways. Really quick, findings and context. I love how people have been asking questions about the policy relevance and how to compare this with previous work. It's hard. I mean, I'll just say that it is hard because in the previous studies that have been used as benchmarks for the impacts of family planning, the baselines and the context are just so different. MATLAB had a 10 percentage point increase so if I went to the MATLAB Bangladesh study and looked at how much the contraceptive prevalence increased over the same time, it's a 10 percentage point increase over 2 years, the first 2 years of the program. But the baseline use of contraception was 1% in MATLAB. So these are like 10-fold increases in contraceptive prevalence. Baseline levels in Lilongwe are much, much higher. So our relative impact is much more modest, and I would argue probably more realistic, just given the increase in the supply side, not just in sub-Saharan Africa, but also more globally. I mean, there have been critiques around the differences, the innate unobservable differences between the treatment and the control group, and observable differences between the treatment and control group in MATLAB, which has kind of questioned some of the internal validity of the program and of the quasi-experiment. But I mean, even if we were to like not worry about that, just the fact that these contexts are so different and the margin to move contraceptive prevalence and access is so different in these contexts, like speaks to what the relevant contribution of this study would be relative to what has been produced before. Yeah, so going back to what worked, lots more to do. Counseling seems to really have shaped preferences. But when it comes to like acting on this service, as I mentioned, the transport, like when I do the rough and quick mediation analysis and trying to see like what variation seems to be playing more of a role in utilization, but also in downstream outcomes, transport seems to be a pretty important feature, and particularly salient for this sample, where they have a small child to care for. They're really averse to public transit options, particularly in this context where safety and mobility is like really, really a concern. Women are not going to necessarily get into public transport on certain times of the day. I have a whole other study that I'm happy to talk to you about with gender mobility and public transport in Ethiopia, where mobility patterns for women are just different than for men. How women think about trip chaining and like adding on other like adding on family planning as part of their suite of services that they are willing to access anytime they go out of the house. It's another add-on that creates a lot of impediments, particularly when they have another child that they have to like board a bus with. Probably the most costly feature of all of the components that I provided. Actually, if anybody wanted to know how much on average did a woman spend on reimbursement for family planning is already it's already cheap, subsidized by the governments, even in the private sector. And on average, over the course of 2 years, women spend about $3.50. Yeah, that's like all of this reimbursement. So we provided reimbursement and coverage for like much more than what women actually spend in terms of the actual service themselves. This, by the way, also includes, but this excludes the cost of transport. So if we look at transport and counseling and all of our services combined, it's about $26 per year for what women were spending on our full on average that women were spending on taking up any of our services. Yes. Excellent. I love it. Okay. Yeah. 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 Mm-hmm. Injectable. Yep. Mm-hmm. Yeah. Mm-hmm. Mm-hmm. Yeah, yeah, an implant. Yeah, yeah.
wondering.
Yeah. Yeah.
My question is,
Possibly. So one of the challenges is that, like, so the 3-month injectable, it's the most prevalent. It's the method that is actually most recognized in Malawi. Like, I mean, and even in the public sector, like counseling around the 3-month injectable is almost like non-existent, like negligible. Like you can, like women go to the clinic, there's like a nurse who goes there and they just literally go injectable. Everybody just gets an injectable because it's the easiest to administer. And from the supply side, like there's a lot of provider bias towards providing that, like that method, particularly because it's so easily facilitated. However, if women, particularly postpartum women, they don't have the opportunity or the time liquidity to be able to like move, like to go back to clinics, even if they were close by, because they have other priorities, particularly postpartum with around childcare, it becomes like the implant seems to have been become much more salient because our counselors were not like, I mean, we were very cautious about like what types of counseling we were giving, and we were giving counseling on all methods that were available at the clinics that they had access to. So we were not putting more preference on injectables, not preference on implants. So, and as like high quality family planning should, like, I mean, like trying to minimize any provider biases or preferences that come from the supply side. But what women actually did want was that's like they really, I mean, we did follow-up debriefing and qualitative work, and what they really were preferring was not having to go back and re-engage with the provider side, especially following a delivery, particularly because the small, like immediate postpartum women, like they would oftentimes in not just in family planning, but also in postpartum maternal health, women often disappear from the health system following delivery, and they only show up usually during vaccinations, which is like, it's all the cognitive attention also goes towards children. And so it's, I mean, especially if you're waiting like 4 or 5 months after delivery for vaccination schedules to kick in, then the women already may have been at risk for subsequent pregnancies, especially if they could get pregnant as quickly as 3 months later. Right. So there's a lot of things at play, and we're still trying to disentangle exactly what the transport did, because it seems to have like alleviated, like the transport seems to have alleviated one of those like first order like structural barriers. And then how that cascades to like changing preferences for methods now that women may have not expanded their choice set, how those like, you know, if you're thinking about what, like if making preferences or choices over a full set of alternatives, like they may have expanded the choice set, they may have reduced the constraints, and now more choices may be feasible. And that plus the fact that both insertion and removal are covered, and that there is a clinician at all of these like facilities that actually can do both, that was an important part. Because if you go to the public sector and ask for a clinician to give you an insertion of an IUD or an implant, very few, they're just totally overwhelmed with other services. Like the clinician who's doing IUDs and implants is doing like 50 other things related to MCH and like malaria and HIV. And so they're like the time to actually spend on a clinical service at the public sector is very, very low, which is why like even counseling, and what motivated my other studies, like counseling times, like for individual counseling in clinics in Malawi is like 4 minutes, 3-4 minutes. So if you're thinking about like how much capacity could a woman get in terms of like, you have 15 methods, each method has about 10 attributes that you want to talk about, like, you know, effectiveness of preventing pregnancy, side effects, whether it prevents HIV, dual protection, in like cost, etc. It just becomes, it's infeasible, right? If you have all of that to be provided in 4 minutes. So definitely more work to do on like thinking about how this is actually fundamentally changing preference structures. Yeah, sure. Oh, we're out of time?
So,
Yeah. Please. Yeah,
next week, we'll be back here. So the talk is being.
great, thanks. That was great.